In this lesson, we're going to be looking at the premature junctional contraction. So remember that this is not an arrhythmia itself. This is an interruption. So you'll have to analyze the baseline rhythm first and then identify the premature junctional contraction. So let's get started. So we're going to begin with the first arrhythmia. And this is what it looks like on print with the normal sinus rhythm as the baseline. So you can see I've got my beautiful P wave, my QRS complex, my ST segment here is a little bit lagging. So there might be some ST depression thrown in this one as well. And then we have this T wave and we have another complex and we keep going along and all of a sudden, boom, we have this funky thing right in the middle of our normal pattern. When we compare this to normal sinus rhythm, what I want you to notice is that this particular QRS complex does not have a P wave in the beginning of it. Remember, there are 3 different ways the P wave can show up. Previous to the QRS complex, but inverted. I don't see that here. It might be buried inside the QRS complex. And this ST segment does look differently than all the other ST segments. This has a nice flat line. This does not, and the next one after also has a flat line. So my P wave is probably inverted here in the QRS complex. Or it can come after that QRS complex. But what we notice here is there is no P wave. So if there's no P wave, the SA node is not in charge of this beat. And the atrial tissue is not in charge of this beat. So something else is going on. This is the characteristic hallmark of a junctional rhythm, is that P wave change. But we don't know if this is a premature atrial contraction. We don't know if it's a sinus pause. We got to do our analysis. I mean, at this point, having taken level 1, you probably can recognize why it's not either of those two, but let's take a look. The rhythm will be per the underlying rhythm. So in this case, this might be a sinus. It is a sinus rhythm because of that SA node being round and upright. But is it a normal sinus rhythm, a sinus tachy, a sinus brady? I don't know. I have to do my analysis. The rate will be again per the underlying rhythms. The P wave again would be inverted, buried in the QRS or after the QRS. The PR interval, if it was present, would be less than 0.12 seconds. QRS complex will be normal between 0.06 and 0.12 seconds. The QT interval will be per the underlying rhythm. In this case, between 0.36 and 0.44. And the ST segment is flat, or it may be rounded if there's digoxin toxicity. So here's the first clue. We're going to be talking about digoxin in this section. The key thing I want you to recognize here is the change in the P wave and the PR interval. Now I want to talk about digoxin for a few minutes. And digoxin is typically used to treat atrial fibrillation, atrial flutter, SVTs, and that's because there's too much. When atrial fib and atrial flutter are uncontrolled, there are too many signals getting to the ventricles and the ventricles are contracting too quickly. And so digoxin is used to slow that down, and it does that in 2 ways. One is it increases the calcium into the cell and staying there, and it inhibits, it actually prevents this process where sodium and potassium go back to their respective areas. So by keeping sodium and calcium inside the cell, we have a stronger contraction, we have a slower conduction system, and so digoxin is used to slow conduction. So when we have digoxin toxicity, we have too much digoxin available, this pathway may be super slow. And so I may have a sinus brady, but boy, it's taking a really long time to get to the AV node. As a result, the AV node recognizes that the heart rate is less than 40 to 60 beats per minute because that's its intrinsic firing rate. And it says, okay, I need to do something here, and it sends off an impulse. Now, just of interest, young, healthy individuals who, when they're sleeping, have a really heightened vagal tone response, like their heart rate goes low, they will often have periods of junctional arrhythmia without
clinical consequence. It's benign.
So when we have therapeutic levels, we have what's known as the mustache on the ECG. And so it's a slurring of the QRS to the T wave that can occur. And we've mentioned this in level 1 as well in terms of it being a normal physiological feature in some younger adults. But when we see this, here we have a P wave, we have quite a prolonged PR interval in this particular example. My QRS, and then we don't have that deep spike where it comes back and the J point is missing. Instead, it slurs into a T wave. And this is known as the mustache. Now, signs of digoxin toxicity, aside from ECG changes, we need to know what to be looking for in our patients. So in terms of the central nervous system, they might be confused, they have a headache, and they're fatigued. Pretty common and vague symptoms, but we're going to put this together with ECG changes. And we may also notice changes in their vision. So potentially they have blurred or double vision, or they have the yellow-green halos. They'll talk about how the world looks a bit yellow and green around them. Cardiovascular, obviously ECG changes, and the GI are pretty, again, common, very non-diagnostic. So we have nausea, vomiting, diarrhea. Maybe they're not eating very well, but they have some abdominal pain. So pretty common. Now, digoxin toxicity can cause any arrhythmia except atrial fibrillation and atrial flutter, because those are being initiated above the AV node, and digoxin toxicity is slowing the pattern through the AV node. Another common manifestation would be premature ventricular contractions, which we will talk about in the ventricular section. So there are many factors that can influence the metabolism and the absorption of digoxin in the body that would put our patient at risk of digoxin toxicity. If they are using this concurrently with other medications to control the cardiac vascular system, quinidine, verapamil, amiodarone in particular will increase plasma concentrations of digoxin, so the amount of digoxin that is available for use. Hypokalemia. Now, this is one thing people often don't think about, but when patients are eating licorice at the bedside, it can actually deplete our potassium levels and create a hypokalemic picture. If they're on loop diuretics, that's another one that will deplete potassium levels in the serum. Hypercalcemia and hypermagnesium, hypothyroidism. If they've had a heart attack, so we have irritated tissue already. Kidney impairment, if we're not able to excrete that digoxin, then we're going to have more available. And obesity is another one. Treating digoxin toxicity, first of all, we need to recognize it. So we want to stop that digoxin, and we want to give digibind if it's available. And that will bind the digoxin that's in the system and decrease its availability to cells. Of course, we want to be reviewing medications, electrolytes. We may need to supplement with that, and looking at our caffeine or alcohol or nicotine intake to see if that might be the cause that's increasing the digoxin effect. In the next section, we're going to be looking at junctional escape arrhythmias.